This conference will now be recorded.
Okay, so all of you, welcome to class. So today what we'll be doing? So today we will be doing sterilization, postnatal contraception. Okay, and there is a few teaching of a cardiac patient and then question answers. And today will be the last class for contraception because we have covered everything. Now, what like in the uh, actually whenever a couple is thinking of sterilization, so there is a counseling. Okay, so and in that counseling actually they both of them has to be seen together. So for part 3 people this is important, like for sterilization and fertility stations we always want to see them as a couple. Okay, so but it is important for part 2 also. So these there are these so whenever a couple is thinking and they want to go ahead with the sterilization, so there are few things that has to be made clear before they go ahead with the sterilization. So what are the important point that has to be covered in a counseling, important for both part 2 and 3 people? So first of all, there should be a verbal information and written information. Okay, you can't do it just having a only speaking to them. You have to give both verbal and written information. It has to be ideally conducted with both partners. Okay, so make it sure that both partners are there, because you already know fertility is such kind of an issue where not a single person is involved. It is both male and female. So we have to be seen as a the couple or both partners should be there. You have to give information about sterilization procedure, and you have basically you have to tell them that they will not have an idea what is sterilization, whether it is a permanent method. So you have to kind of make them very clear that it is a reversible and permanent form of sterilization. Then sometime UK people, they usually have many relations. Maybe later on they fall in any another new relationship. So now they will come to you. Yeah, we want to go ahead with the pregnancy. Now please do a reversal for us. We want to redo this operation for us. Then important thing that what you have to remember, that reversal of sterilization is not funded by NHS. That means if they want to go ahead with that operation, they have to pay it from their own pocket. So this thing is very important, this funding issues, because you must always be knowing that in NHS, whatever is the healthcare provided, that is free of cost. Okay, for everyone it is free of cost. So there are certain services in NHS, uh, for them, NHS like national health system will not pay. So reversal of sterilization is one kind of procedure where there will be no payment by government, so they have to pay from their own pocket. So it is important to know. Apart from this, during counseling you have to make it sure you will explain them that vasectomy is better. Why? Because it is safer and it is quicker to perform, because you're not opening any abdomen, it is superficial procedure. You will explain them about LARC, that is a long acting reversible contraception, and there are certain predictors for regret is there. So you have to kind of do all see whether any predictor for regret is there or not. We'll be just discussing what are the predictors for regret. Then sterilize, you have to make it sure you will explain them that there will be no protection for STD. So they have to continue with the safe sex practices. And also you have to highlight that till their sterilization has been done, so they should continue using contraception. Otherwise, they will come and for sterilization, maybe she's already pregnant. They should be informed decision. Informed decision means that you will explain risk benefit alternate to this patient, and she has to make decision, or the couple has to make decision, like whether they want to go ahead or not. So it is an informed decision in obtaining valid consent, and it has to be recorded and documented in their clinical requirements. So it all this counseling point two, the points counseling points are important for part 3 people, because everything they have to do in this station, because this is very common station. And for part 2 people, it can be asked in your SBAs. So it is important to know what the things the couple has to be explained beforehand. they are going for any sterilization procedure. Okay, now, so and sometime it is important for part 2 people, like sometime you will find that she wants to go ahead with the sterilization, and you think the patient is not has got no capacity. In that particular situation, this procedure cannot be done. You have to take legal advice. Why legal advice? Because it is permanent removal of fertility. So if the patient is mentally incompetent, this operation cannot be done for her. You would require legal advice. So this can come as an SBA for part 2 people. Written and valid written and consent has to be taken, that you all that I just explained. Also it has to be put in their clinical record. So all this recording, documentation is very important, and it has to be informed decision. I just explained that as well. Now sometime you will find question from this also, like whether the patient should be examined and or not, because all the time they are not examining patient. Like if you see your antenatal guideline, few they're not examining patient at all visit. For example, in your HMB guideline also, they're not examining all the time patient. So like if the patient is coming in the clinic, it is not that they would always examine that. But what is about explanation examination before sterilization? So what they are saying, for all history should be taken, and also for male, if they are going for any vasectomy, a scrotal examination has to be done. So either it has to be done at the initial visit, or at least one time before going for this procedure, this examination has to be done. You already know you are taking a patient for invasive procedure. Why you will not do examination first? You have to examine. And for the male, scrotal, and for the female,
Yes, to the patient.
so if the now if she's for male, scrotal examination, and for the female, it would be like by manual examination. For a female has to be done. So either you will do at initial consultation, or you can do it before they go for procedure. Okay, so examination has to be done here. Now these are the indicators for regret. This is important for part 2, because it will come as one of SBA. So you have to know where the regret can happen. So it will be like if the young patient is coming and her age is less than 30, high chances of regret. If she is nullipara or low parity, that refers to less than 2 children or 2 children. So these kind of people, they will have high regret. If they are unhappy if they are unhappy not being in a relationship, if there had been a remarriage, change of partner, change in the relationship status, any psychological problems or any psychological issues are there, if any force is going on by their partner or spouse, and if and the timing in relation to pregnancy. So what they say, if the sterilization is done just after delivery, that is in postnatal period, or after abortion or post abortion, in this particular situation, uh, in this like chances of having a person having regret will be more. So it is really important to all of this you should know, because they can it can come as an SBA, where one of the different thing they will put, and that will be the answer. So you have to know this. And it comes in part 3 also. It is a station basically of part 3. Then what they want, that if these type of people are coming and they are asking you for sterilization, you have to take some additional care in their counseling. Like you have to really ask them why they want to go for only sterilization, if these are the issues are running. So additional care or counseling is required, and this part is very important. like if the cesarean section is done, then in that particular situation, this sterilization or tubal occlusion, it will never be done without consent, and usually consent is taken 2 weeks before in advance. So like in our countries, we just ask them and we do it at the time of surgery, cesarean, but in UK it is not like that. So it has to be informed decision, it has to be valid consent, and it has to be discussed minimum 2 weeks before. Okay, so this part is important. You will get the part 2 people will get as an SBA, and part 3 people already there is a station about this slide. So part 3 people, they know there is a station. Now some like facts from the guideline about the sterilization. So about the male sterilization or vasectomy. So two things like you have to know. So one is NSV. Everybody knows what is NSV. So this NSV is non-scalpel vasectomy. So what they actually do in this NSV, they make a puncture wound on the scrotal skin to why only a puncture, they will access the vas and they will occlude it. Okay, they have got a specially designed fixation clamp is there that will encircle and firmly hold vas difference without penetrating skin. So this way it is done in this particular NSV procedure. Usually they are not using any scalpel, so they are making a puncture, and with the specially designed clamp they are holding and fixing a vase. Then they do with a sharp tip dissecting forceps, they puncture skin and sheath around the vase, and so they create a small opening in the scrotum. Then this vase difference is ligated, and the same procedure is done another side. Okay, so this is just a way of their promotion, that there will be there will be no scalpel, so there will be no cut, but actually there is a puncture in the skin, and with the sharp dissecting forceps, and with this puncture and with this clamp, they are just doing this vasectomy. Okay, so in this small puncture, so similar kind of the puncture will be made on the another type of skin, other opposite side, and the vas will be then like it will be ligated on the other side. So this in this particular method, the only difference is there, they are not using scalpel. So it is promoted everywhere, but in UK what they are doing is MIV. And what is this MIV? It is minimally invasive vasectomy. So what they do in that, so they have usually modified NSV. They in this particular method, it is kind of a minimally invasive, and in minimally invasive skin incision will be less than 1 centimeter. So they will make less than 1 centimeter incision. They will do some dissection. Then vas will be they will dissect it, and then the vasectomy will be done. Then with the tight dressings, they will just close the wound, and they will not put any sutures. Okay, so there will be no skin sutures at all. So if what UK people or what the guideline says, if they are doing MIV or minimally invasive vasectomy, in this particular situation, they are using scalpel, because they are making nick on the skin, and also they are using surgical instruments. And what the guideline says, if they do MIV, then it has a less early complication as compared to other method. So this is different in UK guideline as compared to what is the procedure that is done in other areas. So all other countries or all other area, they are doing NSV, that is non-scalpel vasectomy, but in UK or in UK guideline, It is MIV, that is minimally invasive vasectomy, and the skin opening is less than 1 centimeter. And they are using scalpel. So this part you have to know, because sometimes it may ask for part 2 people in their SBAs or in their EMQ. Okay. Now, few things about anesthesia. Why it is important? Because sometimes it will be part of your SBA stem. So it can be done under local anesthesia. And in the local anesthesia, what they say that if it is if they are putting local anesthesia that is warmed and near to the skin temperature, in that particular situation, like pain associated with injection will be less. Apart from this, local anesthetic can be with adrenaline or without adrenaline. Third thing, anesthetic administration is done to the subcuticular tissues and also to the vas deferens. And what they are saying, use very fine gauze needle has to be used. If they are using very fine gauze needle, then actually the pain will be less. Okay, so these few things are it is important to know. Why? Because the same wordings you will find in some stem of your SBAs. Okay, to sum up, it is done under local anesthesia. It has to be warmed local anesthetic to decrease pain. It can be with or without adrenaline. It is infiltrated into the subcuticular tissues around the vas, and also it you have to use a really fine needle, because if you use less like very fine needle, so pain will be less. So this about anesthesia before vasectomy you have to know. Now, what is the method for this? So it is usually what the guidelines says. It has to be cauterization followed by division of the cauterized segment with or without excision. Okay, so first at the first they will cauterize it, then they will cut it or divide it. Maybe they can remove one segment or they cannot remove one segment. Only division can't do. Why? Because it will recanalize. Okay, so if the division is done, then to either divided and you have to put some cautery, or you have to ligate them and you have to do some facial interposition. Otherwise they will come together and unite. And for, as you already know, it is a like through a small skin incision it is done. So it can clips cannot be put, otherwise they will erode from skin, and also the patient will feel like the different sensation will be there because it can be felt. So the clips cannot be used, that also. So at least remember one point. So best method according to guideline will be cauterization followed by division with or without excision of the vas deferens. Then routinely they are not when they excise it, so routinely they are not sending cut pieces or excised portions of vas deferens for any kind of histopathology. It is important to know, because you will get one of the SBA with this stem in the answer. Then if this thing is really important, confirmation whether the procedure is successful or not. So what they say, so first sample after vasectomy has to be semen sample has to be analyzed after 12 weeks, until they are confirmed that azoospermia is there. They have to use contraception. Why? If they don't use contraception, then pregnancy is going to happen still after vasectomy. And if you don't explain this to the patient, then be ready, there will be a litigation. So this part is important, you already know this. Apart from this, what they say that sometime they are sending postal semen samples also. So if they are sending it by post, then in that particular situation analysis for sperm motility cannot be done. Okay, it cannot be done. And usually routine. So if one time they have confirmed that patient has got developed azoospermia after 12 weeks of the post vasectomy semen analysis, in that particular situation, no need to do second sample. So this part is also important because you will get this also in your SBS. Now this part is really important. So what is considered to be vasectomy failure? You will get this in questions. So now if after 7 months of the procedure, any single motile sperm they found, it is a vasectomy failure. And after 7 months, if they found more than 1 lakh of non-motile sperms, then also it is vasectomy failure. Because you can see it here. So I have just make the headings here from this part only. This part you will get questions. This part, this number, both of the numbers are important. I'm repeating it again. So according to guideline, if there it is a motile sperm after 7 months, or if it is a non-motile sperm more than 1 lakh after 7 months, okay, so this will be considered as a vasectomy failure. You have to learn this. You will get question from this slide always. Then this part I have discussed. So additional contraception after vasectomy, first 12 weeks until azoospermia has been confirmed. Second, until less than 1 lakh non-motile sperms are there. Okay, so more than 1 lakh non-motile sperm, it is considered as a vasectomy failure. Okay, so at least so additional contraception has to be given 12 weeks after first sample till the confirmation of azoospermia is done. This is one thing. Second, if you find that there are certain non-motile sperms are there, then also the sample will be repeated. So if it is till they are less than 1 lakh non-motile sperm, you have to ask this patient to continue additional contraception. So this also you will get question from here. So you have to learn this. Then few things, this part is also important. Sometime when the vasectomy is being done, they will find only single vas is there. On the other side, second side, it is not present. Then in that situation, there should be like you should think, or the person who is doing vasectomy should think there could be possibility of unilateral renal agenesis. So a renal ultrasound has to be done. Patient should be sent for renal ultrasound. But sometime if you think if the person who is doing vasectomy thinks no, it is not single, there are two vas. So how two vas can happen? No, it is second vas like structure that is appearing is not a vas. It is an ectopic, it could be a ectopic ureter. So in that particular situation also you have to do additional investigation for the confirmation. Maybe further further assessment by urologist will be required. Okay, so this part is important because you will can get an SBA from here. Okay, the person was doing vasectomy and there are two vas. So what to be done? So your answer will be there could be possibility of ectopic ureter. Additional investigation should be done for the confirmation and referral for to urologist should be made. Okay, so this will be the answer that you have to give. Now, post vasectomy advice. You will get question from this part also. So what post vasectomy advice is there? Actually, they should be explained. Sometime if hematoma can happen, if they find that the swelling is there that has been increasing, so there could be possibility of scrotal hematoma. Post-operatively, usually they are giving this non-steroidal anti-inflammatory drugs or NSAIDs for pain. The patient has to refrain from any kind of strenuous activity. Also, they have to do abstinence from the sexual activity at least from 2 to 7 days post procedure. So 2 to 7, so you will get SBA from here. How much rest, how much abstinence is required? It is 2 to 7 days post procedure, and they have to wear tight undergarments or tight underpants, and the athletes support at least for few days, including initial 48 hours. So you will get question from this part also. And you will also give when they have to send semen for further analysis. Okay, so this part is important for part 3 people also. It can be a role player station. Patient is going for vasectomy, and you have to kind of counsel that patient. Okay, and for part 2 people, at least this number is important. So they have to refrain from sexual activity for at least 2 to 7 days, and also support, minimum support is required for 48 hours or longer. So there are 2 SBAs here. Now actually also this can come as SBA. So routinely they are not using prophylactic antibiotic before vasectomy. There are some procedures before them, before those procedures they use prophylactic antibiotic, like in our countries, the before operation and in post-op period, they are not giving antibiotics to all surgical patients. So in UK, this practice is different, because they claim high rate of, they make all these aseptic things. So this part you have to remember, that prophylactic antibiotics are not given before sterilization. And usually what they say, whatever this cleaning of skin that has to be done, this will be um, according to the infection control protocols, what is there in their hospital. You will get question from here. Then this is very famous question. Failure rate of vasectomy is 1 in 2000. So you have to kind of remember this figure. Also you have to remember this percentage, or you can calculate in the exam also. So it is 0.05%. These numbers are important. You will get whatever the numbers we are doing today, one question maybe you get in your exams. So sometime after vasectomy, pain is there. So usually what they offer as a first line will be NaCID. But sometimes this pain is so much, they have to do a reversal of vasectomy because of this chronic post-vasectomy pain. So in that particular situation, also you have to explain to this patient that surgical intervention can be effective, but still like some amount of pain may be there. So there is no permanent cure. Okay, this is also one SBA, stem of SBA. Like if the testicular cancer risk is not associated for vasectomy. So if the vasectomy is done, there is no increased risk in any kind of testicular cancer. Because sometimes if the role player station, even your role player can ask this question. Then sometimes also vasectomy reversal is a complex surgery. Only just see this, no need to remember this number. So if if the vasectomy reversal is done, less interval, less than 3 years, so patency you will be able to achieve in 90% of the patient. Pregnancy will be 75%. So the more interval is there, so there will be less patency rate and less pregnancy rate. So in this particular situation, though the high patency rate is there after vasectomy reversal, but still the pregnancy rate will be less. So this is all about what I have to say according to the sterilization guideline about vasectomy. Till now, till vasectomy, any one of you have got any question can ask me. Otherwise,
Hello, Dr. Priyata. Can you
yes,
please tell me about that urologist part once again?
yeah.
Yeah,
So
this part. Yes.
yeah, okay. So now, if unilateral vasectomy is done, because one side, the person who is doing vasectomy, he was able to find vas. On the other side, he's not able to find vas. Then, what could be the possibility? Maybe there could be possible one possibility, like you are not able to find it. Another possibility, maybe it is not there. because maybe that side renal agenesis may be there, because all this developmental thing of kidney and reproductive things are related. Maybe kidney is not there, that type, maybe vas is absent. So what you will do, you will arrange for a scan to find out whether the opposite side kidney is there or not. So if that situation come in the exam, your answer will be like patient has to be said that they have to go for additional contraception until the sterility is confirmed, or he is completely azoospermic. Second part, you have to say that patient has to send for ultrasound, renal ultrasound, because you need to make it sure that others that development is fine and other side kidney is there. So this will be kind of one scenario. Okay, number one. Number two, if you find bilateral vas is not there, then also you have to send this patient to urologist, because in that particular situation also there could be possibility of that cystic fibrosis where both side vas are not there. Third situation, you are doing vasectomy and you find okay there are two tubes from there. How it can be two vas? It is not two vas. Maybe second tube what you found could be an ectopic ureter. So what you have to do, you have to arrange for again an ultrasound to find out whether there had been any associated anomalies there. Okay, so now if any of these things are there, you are thinking any anomaly, then what you will do, your referral, you have to arrange for investigation to find out whether there had been any anomalies there. So you will do investigation for that, or apart from this you have to send this patient for urology opinion. Is the thing clear?
Yes, yes. Thank you so much, Dr. Priyata. Thank you.
Welcome. Anyone, any other question about vasectomy?
Hello.
Yeah.
Ma'am, if a patient has given consent in the antenatal clinic for tubal ligation, but she has not signed the form, and at the time of delivery she is requesting after delivery she wants tubal ligation, so it will be done or not done because she has not signed the form.
Without signing it cannot be done. She has to sign 2 weeks before. It is not an emergency procedure, it is not life saving procedure. Why you will do it at that time? It has to be done clearly 2 weeks before.
Even though she has give means say yes in the antenatal clinic, but she has not signed the form, so there will we will not do, no, means that
No,
it's
no,
not,
no,
it will
no.
not be done.
It no, because it is like what they say. It has to be informed consent, and you have to give a cooling off period. So cooling off period, like patient has to think and take decision. All of a sudden, it is not done. Okay, all of a sudden surgery done will be only those surgery that puts patient's life at risk. But here there is no risk. Okay, so it will not be done unless she has given you a valid consent, and ideally that has to be taken 2 weeks before.
Okay, thank you.
Okay, if yeah, it has to be verbal plus written consent, both. Okay, so now
Thank you.
this much information is only required for part 2 and part 3 MRCOG exam. More than that is Nikki, if they have given written consent but they want to postpone, yeah, it is their choice. You cannot do that. Okay, so another question is that if the patient has signed consent 2 weeks before, now she says today, no doctor, I don't want to go for sterilization, then you have to respect her wishes. You will say yes, perfectly fine, we will not do it for you. So patient has got, in UK patient has got right, they can withdraw their consent at any time before surgery they want. I think now the question is, your question is clear, Nikki. Okay, patient can withdraw consent whenever they wish. They have got right. Okay, now coming to tubal's second part of sterilization, male is done. Coming to female, it will be tubal occlusion. So so these are the ways it is done. So it will be like Pomeroy's technique, where these the loop is made cut, and second type is the Filshie clip. Third type is the Phillips ring. Okay, so these are, though if you find literature, a number of methods are there, but you have to, as we are doing studying for MRCOG, so we have to just have a knowledge about UK thing and UK guideline, because you have that much is required. In UK, what they do is this second procedure. Usually in UK it is laparoscopic, and they apply Filshie clip. So this is the Filshie clip, and this is made up of titanium. Okay, but this is again from the guideline only. I have not taken anything from uh, any other source. So they have what Pomeroy technique. Pomeroy technique is a widely used technique for ligation. What is done in the Pomeroy's technique? Suture, a loop is made in the middle portion that will usually consist of ampulla, and then a suture material is tied, that will be absorbable suture material, and then top portion of the loop is usually excised. Okay, usually we do this Pomeroy technique. Then what happens, as this suture material is a absorbable suture material, so it will it will get absorbed, and after that the ends of the tube, they will move away. Okay, so usually it destroys 3 to 4 centimeter of tube. Okay, you will get SBA from here. Okay, it will Pomeroy's method, it destroys 3 to 4 centimeters of fallopian tube. Therefore, now if you have to do reversal, then it is really difficult. Why? Because there will be so much of shortening of tube will be there. Okay, so this is about Pomeroy. Now a second version of it is the modified Pomeroy technique, that is also known as Parkland technique. What is done in this technique? Small portion of fallopian tube is separated from the mesosalpinx. Each end of the tube is ligated, and in between the portion of tube is cut and sutured and then excised. Okay, so in Pomeroy technique, they are making a loop, and they're putting stitch at the bottom of it, then they're excising the top part of it. So this is the Pomeroy technique. In modified Pomeroy or Parkland technique, they remove small part of tube from the mesosalpinx. They are tying each end of it. Then the portion in between the suture, whatever they have put at the two ends, it will be then excised. Okay, so this way, these techniques are different. Okay, now in postpartum sterilization, so
Ma'am, I had a
either,
small doubt. Hello,
yes.
hello. Ma'am, just one doubt. Ma'am, here in India or generally also everybody does modified Pomeroy mode. So, but there in UK still Pomeroy technique is the most widely used. If they ask between modified Pomeroy and Pomeroy, we have to pick Pomeroy for most widely used.
Your voice is not clear.
Hello, ma'am, can you hear me? Hello.
Yeah, now yes, now yes.
Ma'am, between modified Pomeroy and Pomeroy, here in all we do modified Pomeroy only for all patients, but there Pomeroy is still the most widely used technique. If they ask the most widely used technique, we should pick modified Pomeroy or Pomeroy, ma'am.
It is like according to their guideline, it is a next it is modified Pomeroy technique or Filshie clip, but basically they are doing Filshie clip. Even they are not using doing this the Pomeroy technique, because most of the sterilization they are doing lap, and they are using this Filshie clip. Even in the postpartum sterilization, usually in this, because the uterus is big, If laparoscopic is not done, maybe they are doing mini lap, then also they are putting this Filchie clip. So like according to their guideline, it will be Filchie clip and modified Pomeroy technique. Is it clear?
Okay, thank
Because
you,
it
ma'am.
is from
Okay.
their
Yes,
guideline.
ma'am.
Yeah, it is from their guideline.
Thank you.
In India, we do like Pomeroy technique.
Yes, ma'am. Thank you,
Okay.
ma'am.
Yeah. So this is from their guideline. So this is the answer. Okay. So in
Okay,
in
ma'am.
the postpartum period also, both the things can be done. It will be Filchie clip or it will be modified Pomeroy technique. Actually, postpartum sterilization, they are associated with increased rate of regret and increased rate of failure rate. Failure rate will be there because increased vascularity. Maybe when the involution is when the uterus is getting involuted, so in that time maybe it recanalize, chances of recanalization or falling like falling of Filchie clips are more. So it is associated with increased regret and failure rate. Then this is Filchie clip. Okay, so this is the method of choice what the UK people are doing, and this is made up of titanium. It looks like this. Just for teaching purpose I put it. You will not be asked this in the exam. So this is the Filchie clip open. This is the Filchie clip closed, and it is a method of choice, and you will get question from here. So whether you for better occlusion, should we use two Filchie clip? Your answer will be no. You have to use only one Filchie clip. Okay, so routine use of more than one Filchie clip is not recommended, so you have to use only single clip. Now again, anesthesia for sterilization. Usually in UK they are doing it under lap, so it has to be general anesthesia because laparoscopy we usually it is done in general. Apart from this, what they say, like for short-term post-operative, to reduce short-term post-operative pain, they can put topical local anesthesia on the tube. So maybe they spray some anesthesia on fallopian tube. In that particular situation, if they do that, so chances of post-operative pain will be reduced. Okay, so this much you have to know about sterilization, anesthesia for sterilization. Then this part is really important. You will get for it is important for both part 2 and 3. Like whenever you are taking any patient for surgery, any kind of surgery, it is a patient safety. You have to rule out pregnancy. You have to rule out pregnancy first. So you really have to do the pregnancy test first. Okay, so and why? Because if you, and also you have to take history. So maybe this patient have some unprotected intercourse, like maybe 2 weeks back or something. So there could be possibility of luteal phase pregnancy. In that particular situation, you do ligation. Maybe after 2 months after that, she will come with a pregnancy test positive, and she will then say, doctor, you didn't do your job well, and there will be litigation. Okay, so it is must you have to rule out pregnancy first. So you have to take their history. If there had been any unprotected intercourse last 3 weeks, in that particular and they have not used any contraception, or if you think there is any possibility of pregnancy, this ligation or this tubal occlusion method can be deferred. So you will get this, may get this in your SBA, like patient has got 6-10 days back in the same cycle. Now she has and her procedure for ligation is scheduled tomorrow. So what advice you have to give? So your answer will come from here. So there could be possibility of pregnancy. So ideally the procedure should be deferred. Okay, so you will not do this procedure. So this part you have to make it sure, and you have to understand this. So in this particular situation, you have to make it sure that she is not pregnant or by any like previous act of intercourse. Apart from this, if she thinks, if she you think that there could be luteal phase pregnancy, In that also, if you if you think, okay, I will do some curate at the time of this thing, tubal occlusion. So this should not be performed, and this is not a practice. So main message from this slide is that you have to make pregnancy, confirm that patient is not pregnant before operation, and if you have got any suspicion there could be pregnancy, you can postpone the procedure or you can defer the procedure. So this is patient safety. Then this part is important, you will get this as a question. So if your patient is taking CHC, POP, copper T, LNG, LNG IUS, so CHC or POP, she has to continue at least 7 days after sterilization. Okay, so now today if the sterilization has been done, so she has to continue her pills for 7 days more. And if your patient has got copper T or LNG IUS and you are doing sterilization today, then this removal will be done 1 week after the occlusion. You will get this in the question. So when how long this patient has to continue contraception after sterilization. So this is very important for your questions. Apart from this, if your patient is on implant injection, so just remember 2I, the implant and injection in this particular situation, no additional contraception is required. So even the implant removal can be done at the time of procedure. At the time, like in the same sitting, you are doing her sterilization, and if she is on DMPA injection, no need to use any other further contraception. Okay, so just remember this. CHC POP oral things has to be continued for 7 days. Intrauterine device you have to remove after 7 days. But if it is implant, so or it is injection, nothing is required. Implant can be removed on the day of surgery, like on the day of sterilization. So no additional contraception is required. This part is important because you will get question from here. This is must, like every person should remember it by heart. So a risk of failure of sterilization is 1 in 200, and over 10 years if 1000 operation is done, then failure rate is 2 to 3 per 1000 procedure at 10 years. Both of the numbers are important because you will get SBA from both. Sterilization failure, okay, usually whenever we do, this is important for part 3 also. So whenever we do sterilization, we always counseling station, we always say that there is a risk of ectopic pregnancy in this particular situation. Whenever after sterilization, if their pregnancy test come positive, or if they miss their period, so they have to come immediately if there is a pain, because you have to rule out ectopic pregnancy. So this part I have said, like this question, this we were doing yesterday also. So sterilization gave you protection from ovarian cancer, and there is no association for any other cancer. Just you have to remember one line: sterilization will give protection from ovarian cancer. Now how it is, why it is done, though you people know it already, but actually what the research shows, if the ovarian cancer arises, so its origin is in the tube. Okay, and if you remove that tube, then that means you are removing the place where origin happens. Therefore sterilization is protective for ovarian cancer. With this explanation, you will be able to remember this or keep it under your head. Okay, this also you will get a question. So if the sterilization is done, so her hormones will not change, and usually there will be or no change in the menstrual problem. But sometimes some menstrual symptom, worsening of menstrual symptom, women may report, but again the evidence to suggest that it is because of menstruation is not there. Okay, so just so with the menstruation with the sterilization, There is no change in hormones or menstrual problem. So it is like it will not change anything. Now this part though we have done, again summary of postnatal sterilization. So both Filshie clip and can be used, or it is modified Pomeroy technique. So now you someone has asked this question, now the thing is clear. So method of choice will be Filshie clip and modified Pomeroy technique. Apart from this, if postnatal sterilization is going on, so first you have to explain patient about LAR, long acting reversible contraception. Then again same thing is repeated. So written consent at that if the patient wants to be sterilized as cesarean section, written consent has to be there, and that consent has to be in 2 weeks advance. Okay, so this you will get this as a question. Then if the sterilization is done following childbirth, there is an increased chances of regret. So this much is the summary of postnatal sterilization that you people should know for your exam. And so this is like this is like must a slide that you have to kind of remember. I have sent a screen in the screenshot in the group also. So failure of sterilization 1 in 200, failure of vasectomy is 1 in 2000. Failure lifetime failure rate will be 2 to 5 per thousand at 10 years. Risk of vessel and blood injury at the time of laparoscopy for sterilization will be 2 in 1000. This is a famous question, keep on coming. Risk of laparotomy is 3 in 1000. Death as a result of procedure is 1 in 12,000. This screenshot I have sent, I think yesterday or day before when we were doing questions. All this number, you this is a summary of number for sterilization that you have to remember, and you will get one out of them, maybe, yeah, very high probability in your exams. So now that finishes this female sterilization also. So before moving to postnatal contraception, if any one of you have got any question, can ask me.
Hello, ma'am. I have a question. Hello.
Yeah.
In case of postpartum, even in case of postpartum contraception, the most common is the Filshie clip. It's not modified Pomeroy.
No, it is Filshie clip.
This is Filshie clip, na? After cesarean section, that is postpartum. Even after cesarean section, the most common is Filshie.
Yes.
Okay. Thank you, ma'am.
Basically, you will get question from this slide. Just do it by heart. Okay, no question. Now coming to postnatal contraception, because this part is left. So postnatal contraception. So this you will get question from this stem many times. So she has given birth for 2 weeks back. She had intercourse. Now she was very worried. She came to you. What will be your answer? Answer will be assurance, because first 21 days after childbirth there is no risk of pregnancy. So this patient will not require any emergency contraception or anything, because pregnancy cannot happen first 21 days after childbirth. So answer will be reassurance. Now then after what about implant or IUC? So implant, it can be inserted immediately after delivery, so there is no contraindication. What for IUC, intrauterine device? Intrauterine device can also be inserted when the patient is still in the hospital. Then coming to pill, injection, and implant. So all of them can be started at any time at the childbirth, and there is no contraindication. For IUC, there is something we have to discuss that I'll just discuss. So any type of contraception, POP, POI, that is injection, implant, for such as all progesterone thing, and all and intrauterine devices, both can be started at like any time after childbirth. So these are considered to be the safe contraception. This part is important that you have to remember. For COPD and LNG IUS, there are few things are there. So either you will insert them first 48 hours after childbirth, if that period is already overgone, then they can be inserted after 28 days. Okay, so or 4 weeks, or so this part you have to remember. Because at that particular time, because uterus is involuting, if you insert them, very high chances of perforation is there. So therefore, in between 48 hours to less than 4 weeks, so both CUT and LNG IUS are category 3. When she's admitted in the hospital, less than 48 hours, it is category 1, and after 28 days of childbirth also it is category 1. So you have to kind of remember this second part of it. You know it very well also. It is category 4, category 3, rest it is category 1. And one important thing that we have discussed before also, any kind of sepsis, any kind of infection, active infection, intrauterine device is always a category 4. So if your patient has postpartum sepsis, it becomes becomes category 4. Okay, so this now the things are easy. So in between 48 hours and less than 4 weeks or 28 days, it is category 3. Sepsis is 4. Apart from this, all other time it will be category 1. And this part is also important. Maybe it can come in your question. What is post-placental intervention? Post-placental IUCD insertion or PP-IUCD. So it can be done within 10 minutes of placental delivery. Okay. Another, you will get some question. What is the interval for interval postpartum sterilization? Your answer will be 4 to 6 weeks. So you will get from this slide, you will get a number of questions. Is the thing clear about this slide? It is clear.
Yes, Dr. Priyata, clear.
Yes, ma'am. This also you have to remember what are the contraindication of PP IUCD, because this is from a talk postpartum contraception, because I wanted to include that also in the class because it has to be revised. So these are general contraindications of IUD. Any active any active infection, any unexplained vaginal bleeding or abnormal uterine anatomy or distorted cavity. These are general contraindication for IUD that you already know. Pregnancy specific, any postpartum sepsis, and this you have to remember. Prolonged rupture of membrane. So if the prolonged rupture of membrane is there, then in that particular situation, in that particular situation, chances of infection are there. So you will not put this PPIUCD. You will get question from this part. This you already know. And also if unresolved postpartum hemorrhage is there. Okay, if it is unresolved postpartum hemorrhage is there, then also it will be kind of pregnancy specific contraindication. So these three things you have to remember, or you have to know it, because you can get this in the question. So any sepsis, you can remember intrapartum, postpartum sepsis. Just add on to your list prolonged rupture of membranes and also unresolved postpartum hemorrhage. Like if the hemorrhage is going on, how you can put a PPIUCD? Just remember this because you will get question from here. Now this I wanted to just show you. So this way how the PPIUCD is done. So usually during cesarean section, what they will do, they will remove this copper T or device from the inserter, and they will put it centrally at the fundus. Okay, so here they will put it after delivery of placenta, and then manually they will do it, so the threads will threads will be directed towards internal os or cervix. And important part is that threads will not be cut or untrimmed. So untrimming of threads will not be done. After that, uterine incision will be closed in the usual way. What you have to take care of, that the thread or device you should not take in your stitch, because if that thread is taken in that particular situation, a removal of the device will be difficult. So this way within 10, so this is about post placental insertion, that is done within 10 minutes of placental delivery. This is just the picture and this is from the top. So they will put it here at the center of the fundus. They will close uterus in a usual manner. They will make it sure that the threads are directed from the internal os towards the cervix. Okay, so this way it has to be done. Fine. So because it is from TOG, so I thought of putting it in the slide here. Apart from this, as the threads are not cut, so patient will be called usually at 6 weeks postnatal checkup. That time uterus will be involuted. That time they will again check this device. At that time they will do the trimming of thread. Okay. Then again, this is for the cesarean section. Now this is for vaginal delivery. Okay, so in the vaginal delivery, after the vaginal delivery also they can do this IUCD insertion. In the important thing what you have to remember, that in that particular situation, like they will remove this from inserter, then they will use a special kind of instrument, and this is a Kelly's forceps. Okay, the name of the forceps is a Kelly's forceps, and it is like, it appears like your sponge holder, and it has got a long curve. Okay, this curve is long because in part 2 this instrument questions are also usually they come. So therefore you have to remember that it is done with a long placental forceps, or it is a Kelly's forceps. Okay, so usually they are putting this type of instrument. Just I think this will be the only question asked during the if they have to do for PPIUCD. Then as the postnatal period is a period where breastfeeding will be done. Now what we have discussed till now is all about intrauterine devices and progesterone contraception. So all progesterone contraception we were using in breastfeeding. What is difference for intrauterine devices, that also I have discussed. Now whatever things we have to remember about combined hormonal pills. Okay, so what they do, that they in postpartum period they have to do VTE risk assessment. So these are the factors they will see in any postnatal patient: immobility, BMI, PPH, cesarean section, preeclampsia, and smoking. So these are the factors where where usually the chances of VT is increased. So this is the risk assessment. So we already, all of us know that in the postpartum period, so there are very high risk of embolism is there, and this high risk is maximum in first 21 days. Apart from this risk factor is there. So there are few things or few facts it is important to know about CHC, VTE, and risk assessment. So now this part you have to remember. If your patient is breastfeeding, okay, then if it is less than 6 weeks, and you then if the CHC is given, it is category 4. If it is 6 weeks to 6 months, it is category 2. More than 6 months, it will be category 1. Okay, so you will get your question in the exam. After 6, patient is postpartum 6 weeks and she is breastfeeding, can CHC will be given? Your answer will come as yes. Why as? Because category has become 2. So in 2 category we can offer her. So that means after 6 weeks of postpartum breastfeeding mom, she can continue with CHC. And if your question is only about for category, so after 6 months of breastfeeding mother, it becomes a category 1. So just remember this. 0 to 6 weeks is 4. No need to remember, everybody knows it. 6 to 6, 6 to 6, it is category 2, and more than 6 months, it is category 1. You will get questions from this, so you have to kind of remember it very well. Okay, so this maybe with this presentation, you are remembering, you'll be able to easily remember it. Now these are the few things. So now if your patient is not breastfeeding, so usually we do risk assessment. So risk assessment point I just explained: immobility, BMI, PPS, CS, smoking, and preeclampsia. So if your now patient is not breastfeeding, so they have divided this into 3 parts. Less than 3 weeks. Less than 3 weeks, we already know that postpartum 21 days risk of VTE is very high. So on that very high risk, if she has got this risk factor, so she will become category 4. Now it is 21 days, but she has got no risk factor, then also it will become category 3. Okay, so just remember, less than 3 weeks with risk factor it is 4, without that it is 3. Just remember this way. Now after 3 weeks, come to 6 weeks. 3 to now patient is more than 21 days and less than 6 weeks. So again, just you can just remember, if the risk factors are there, it will be 3. Without that, it will be 1. And after 6 weeks, it is category 1 only. Okay, so like this appears to be a bit clumsy thing, but you have to remember, because this is the slide, you will get many questions, and unless you remember these categories, answering of question will be difficult. So is the thing clear to you people? Is this thing clear?
Yes, ma'am,
Lot
clear.
of, yeah, lot of remember, a lot of like you have to mug up, no other way. So I just put it this way, so like it will become a bit easy to remember. Now someone was asking me, if the blood pressure is high, patient has PET, so can we give CHC? So at that time also I said yes, we can give, and it is usually but it is usually under category 2. So now this part you have to understand: if the pregnancy is complicated by preeclampsia or obstetric cholestasis, everything is category 1. Just CHC will be category 2. Okay, so all kind of contraception you can give to a patient whose pregnancy is complicated by PET and obstetric cholestasis. Okay, every category, everything blindly one. Only PET cholestasis, CHC is category 2. Just remember one line, and you can answer any question, because you will get question from here also. And same is with the diabetes. For the GDM, every pregnancy and diabetes, all categories are one only. Okay, so the postnatal contraception will not be affected at all. This part I have already explained. So for first 21 days, there is no risk of any pregnancy, so no contraception is required. And after 28 days, after 21 days, the choice, if she has got unprotected sex, you have to give her emergency contraception. So it will be LNG, or it will be ulipristal. And if you are prescribing ulipristal, she has to discard milk for 1 week. This part is important, you will get in your question. Okay, apart from this, if she says, no doctor, I want to go for copper, you have to say, we cannot offer you copper, because copper coil will be inserted after 28 days. Okay, so if any patient has intercourse in between 20 days after childbirth and 21 to 28 days, you can give only two options. Oral, copper T will not be an option for her, and with UPA she has to discard milk for 7 days. Additional contraception, this part we have done last also. So if the contraception is started less than 21 days of childbirth, so in that particular situation no additional contraception is required. But if the contraception is started after 21 days, so additional contraception will be required. That will be 7 days for every type of contraception. Only for POP it is 2 days. So for POP it is 2 days. For all other, she would require additional contraception for 7 days if the contraception is not started within 21 days after childbirth. You will get question from this also, because this is the only option that can be offered to the breastfeeding mom. So this is lactational amenorrhea method. So like, what are the criteria for LAM? For LAM, she should be fully or nearly fully breastfeeding day and night. No other liquid, water, juice, vitamin should be given in addition to breast milk. And her breastfeeding frequency should be at least 4 times in a day, 4 hourly in a day and 6 hourly at night. So it is 4 hourly in a day and 6 hourly in a night. She should be amenorrheic, there should be no periods, and it should be less than 6 months. If all the criteria are fulfilled of LAM, then success rate is 98%. From every part or every line of it, there will be an question. So you have to kind of remember this. Not very difficult. So fully breastfeeding, 4 hourly in a day, 6 hourly in a night, no periods, less than 6 months. So these are the criteria for LAM. Success rate, this number is important. You will be asked in the exam. Then risk of pregnancy with the LAM. So if she is stopping night feeds, or if she is decreasing frequency of day feeds, if she is using supplementary feeding, dummy pacifiers, and periods has come back, or it has been more than 6 months, so that means the criteria of LAM is not fulfilled, so there will be pregnancy. This part is important. Like about the barrier method, with the condom there is no problem. But if the patient is using diaphragm as a method for contraception, in that particular situation she has to wait till 6 weeks. Why it is important? Because uterus is involuting. In that particular situation, this diaphragm fitting will be difficult, and also sometimes there could be change in the position as well. So it is important that for diaphragm she has to wait for 6 weeks. So that's all about postnatal contraception. That is important to these are necessary from where the question can come. So anyone have got any question till now can ask me. Any question?
Excuse me, doctor, can I ask something?
Yeah, anyone can ask.
Yeah, that additional contraception, which you told for the PUP, it is for 2 days we can
Yeah.
give for
Mhm.
2 days. So others, I wanted to know. So other for the 7 days we will give for the IUS and for injection. For injection, IUS and combine these three only,
Yeah, so
isn't it?
yeah, you are very right, because copper, with the copper, with no additional contraception is required. Why?
Yeah.
Because it acts as emergency contraception also. So
Yes.
with copper we will never give additional. Now left out are these one. So with everything, LNG, IUS, POP, implant, and CHC, so we would require additional contraception. For everything it will be 7 days, but for POP it will be 2 days.
Okay. Thank you.
Yeah, Nivedita, copper-T is used only after 28 days. Why? Because after childbirth, uterus is involuting, and according to guideline also, and like it will take at least minimum 4 weeks time for involution process to happen. And if you put copper-T before that, there will be perforation. So to avoid that thing, they say either you can use copper-T first 48 hours, because at that time process of involution is not started, and your method of copper-T insertion is by using Kelly's forceps. And after 20, after 20, it will require like minimum 28 days for involution to happen. So if you put copper-T that time, there could be possibility of damage you will do to uterus. Therefore it is not put within 28 days, it will be put after 28 days only. According to them, till that time uterus usually will come back to that normal shape, and also that softness of uterus will go. So that time chances of injury will be less. So there is a cutoff of 28 days. Have I answered your question, Nivedita? Okay, few things about post-abortion contraception as well, because this guideline is quite new. So I thought of putting all the things. So post-abortion, the good thing is that everything is category 1, all is category 1. What you have to remember, with the sepsis, intrauterine is category 4. Just remember only one line and your job is done. So for part 3 people also, if the patient wants contraception after post abortion, you can offer anything and everything. All options are open for her, except if the sepsis, intrauterine devices will not be inserted. And emergency contraception, like first 5 days after abortion, if she has got unprotected intercourse, no need to give emergency contraception. After 5 days, emergency contraception has to be given, and you can offer any other choice. You can offer all three choices. Now, IUS after can be inserted. Intrauterine device can always be inserted after abortion. After medical abortion, once it is confirmed that pregnancy tissue has been expelled, so following medical abortion also IUC can be inserted. And for the surgical abortion also, immediately you do the evacuation of uterus, so IUC can be put in. Then at that, if this patient want implant at the time of abortion, implant insertion at the same sitting can be done. Okay, few think they want to, it is important also. Now if your patient say, doctor, I would like to go for medical abortion, and you are giving mifepristone, and she also wants injection as a contraception, and if you give injection, and at the time of mifepristone, that in that particular situation, chances of failed abortion will be high. Why it is high? Because mifepristone is belongs to that SP selective receptor progesterone modulator, and DMPA acts on progesterone. If the both things are given together, so there could be possibility mifepristone will not do its work very well. So chances of failed abortion can be there. So why I'm explaining this, because you can get this as in your questions. Okay, so DMPA is linked with failed medical abortion if it is given at the time of mifepristone tablet. Now, if this we have done also before, with the postnatal sterilization, chances of failure and regret are very high. Post abortion, if they are using diaphragm, and if it is a second trimester abortion, so they have to kind of wait for 6 weeks till the uterus size come back to normal. But if it is a first trimester, then there will be no problem, because in first trimester usually uterus is not that big. Then coming to this UKMAC, after ectopic and miscarriage. Now again same thing. Good thing is that you can put everything only if the sepsis, your intrauterine devices will be category 4. Okay, so now you remember this time by heart. Now in this part you may get question, it is important. If your patient is having, so they will put a scenario, the patient has got like she has come today because she miscarried third time, and now she is requesting a contraception. So if they gave a CHC as an option, so in that particular situation you should not offer CHC. Why? Because why this recurrent miscarriages is happening? Maybe she has got antiphospholipid antibody syndrome. So to a patient of RCM or recurrent miscarriage, we will not offer combined hormonal pills till the investigations for antiphospholipid syndrome has been completed. So this part is important. This is new in this guideline, therefore I have put it here. You have to kind of remember this. This is also important. So if any phospholipid antibodies are there, or if thrombogenic mutations are there, so except CHC, every form of contraception you give, the CHC you will never give, because this will be category 4. You everyone knows it, because of risk of venous thromboembolism is very high. Now this is also important to know, and this is a slight change from your this heredity-form mole guideline. So what they want, so according to this guideline, so if the patient has a complete molar pregnancy, in that particular situation, before she wants to go ahead with the pregnancy, she has to wait for 6 months. This is same in previous guideline also, but this part is different. In this new guideline, we have specified about partial mole. If your patient has partial mole, and if she wants to go ahead with pregnancy, then what the answer will be? If the 2 consecutively monthly HCG are normal, in that particular situation she can go ahead with the pregnancy. So this is only, this line is given only in this guideline. In HMOL guideline it has not been given, but on the other side this HMOL guideline draft has already been put up. So maybe new guideline when the HMOL new guideline will be there, I think within a few months, maybe they will change it there. But this is like different from current guideline. So this part you have to just take care. Maybe before your exam, if the HMOL guideline comes, so how much she has to wait before she planned for pregnancy, and she has a partial mole, maybe in the new guideline also they will update the same thing. So this thing kind of you have to take care of. Chemotherapy, after chemotherapy they have to wait 1 year for pregnancy after the completion of treatment. Okay, so is this slide clear?
Yes, ma'am.
Any you want to see this one? You wanted to see this one? I don't know what you wanted to see. Okay. So yeah, this is the slide. You can see this is from the guideline only. So what is it says? All type of contraceptions can be offered to you. This phospholipid antiphospholipid antibodies positive or mutations. Only CHC is category 4. So CHC is category 4. All other hormone 2 and copper has got no relation. It will be 1. Is it clear? Any wanted this? I think. Okay, this part also I have explained you. Now this part is really important. You have to understand. You will get this part. A number of questions are there. So UK MEC and GTD. Now so you see if the SCG level are normal, if they are decreasing, if they are rising or persistently elevated, in every condition CHC is category 1. You will get a number of questions because in previous guideline the things were different. In the previous guideline they never started CHC until the HCG level comes back normal. But you know that guideline is really 2010 and very old. Now the things has changed. Now if the SCG is undetectable, they are decreasing, they are elevated, your CHC in all cases is category 1. You have to remember it by heart because maximum mistakes are done here. Okay. Then this part you have to all other contraception is category 1. This part you already know. So if SCG are elevated or malignant disease, CHC intrauterine device has to be category 4. But if your patient's HCG started falling, then it becomes category 3. So this you have to remember because you will get question from it. And hormonal contraception, now you can see all hormone are 1 category, so they can be easily started after evacuation. Okay, so there is no restriction for hormonal contraception. That this part you have to be very clear because you will get question from this part. Now decrease if the HCG levels are decreasing and copper T or LNG IUS are category 3. If your patient says, no doctor, I have to go for this only, in that particular situation you have to you can consider, but it has to be done in a specialist setting. As it is a category 3, because SCG are decreasing, so in that particular situation also, if she says, no doctor, I want to go for copper coil, you have to do it in a specialist setting, or you have to take advice from the specialist in this particular situation. Okay, so with this postnatal contraception finishes. Any one of you have got any question can ask me. Any question?
Ma'am, hello, ma'am.
Yes.
Can you hear me?
Yeah.
Ma'am, regarding that LNG US insertion after abortion, it can be inserted any day. Usually, LNG US after 7 days only additional contraception needed, no? But post-abortal, it is up to 5 days, no need of contraception, additional precaution. If it is inserted after 5 days, there is a need of insertion. It's given like that in the... Can you clear
Yes.
that one, ma'am?
So what you are saying basically, additional contraception thing you wanted to say. So actually, with first 5 days of abortion, if the contraception is started, no additional thing is required. Okay, but if it is started, yeah, if it is started later on, any time after 5 days, then additional contraception is required, and it will be 7 days for every contraception, But for copper T, no additional contraception is required, and for POP it is 2 days. Is this what you are asking?
Yes, ma'am. Yes, ma'am. The same thing. That is
So
both different, no, ma'am. For post-abortion is different from routine LNJUS insertion.
yes, yes.
Routinely, we consider up to 7 days.
Yeah, yeah, you are right. Yes, I'm not getting that slide. What I just
Okay.
explained to Ed. So again, yeah, you are right. I get your point. I'm just searching for. So this was you say. So this is
Yes, ma'am.
LNG IUS. So this is LNG IUS. If it is inserted after 21 days of childbirth or after 5 days of abortion, then contraception will be required additional for 7 days. But in normal cycle, if it is normal cycle, then in that particular situation, till first 7 days, if it is inserted, no additional contraception is required. This is what you want to tell.
Yes, ma'am. The say exactly, ma'am.
Yes, 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 you are right.
Okay, ma'am. Thank you.
Okay, so this is the last part that is left from all contraception series. Now we have covered all contraception guidelines. What are there on the web, on their website? Only this part it was different that I never covered, so I have put it here. So this is the last part, cardiac patient, because you will get question from here. Therefore, I have put it here. So summary of cardiac contraception in cardiac patient. Now this is the table from your talk that you already know. So the few things you have to know because you will get questions. So like what are the contraindications? Just to know what are contraindications. So for condom there is no contraindication. For CHC you already know in cardiac disease usually like if it is a ischemic heart disease, if it is a cyanotic heart disease, or if heart failure, arrhythmia, or bosentan use. Usually these are kind of contraindications where this CHC will not be used. Why this bosentan is there? Because it belongs to a group of enzyme inducers. So we already know this, that in cardiac patient usually CHC we will not be giving. Okay, important thing is that you have to know this part. Usually POP we always give to cardiac patient, but you have to make it sure. If your patient is on bosentan, so this is an enzyme inducer. If the patient is on bosentan, in that particular situation, you will never give her POP because it is an enzyme inducer. Because from your knowledge, you will say, okay, cardiac patient, yeah, I can give POP, but please see what the medication she is taking. With the bosentan, you cannot give her POP. And if any patient has got needle phobia, injection and implant will not be given. Okay, important thing is remember to this part only, that if about copper T, okay, in the for if copper T or IUS insertion is there, in cardiac patient, when the dilatation is usually done, so there is a very high risk of this vagus stimulation or vasovagal collapse is there. So you have to be very careful in this patient. So you have to like keep all the resuscitation things ready, and also atropine has to be kept ready. So this thing you have to remember. Apart from this, if it is a sterilization, usually sterilization is not a kind of offer to these patients. Why? Because if the laparoscopic sterilization is done, so lot of gaseous inflation is done in laparoscopic sterilization, and usually it has effect on venous return. So this type of patient, they may not be able to tolerate this operation. So usually if this patient is like stable kind of relationship, so instead of tubal occlusion, we will counsel them for vasectomy. Okay, so these things are like, so this is the summary. This you have to remember. Few things this we have done before also, and I will repeat it again. So if you think your patient is at a risk of infective endocarditis, prophylactic prophylactic antibiotics they are not giving to them. So this is one thing. Second thing, because of cervical stimulation, vasovagal reactions are high, so you have to kind of prepare accordingly. Make all preparations for resuscitation. Atropine can also be given. Apart from this part we have done also. If you want to insert intrauterine devices and your patient is a cardiac patient, and if patient has got single ventricular circulation, for example, Eisenmenger physiology is there, or pre-existing tachycardia or bradycardia is there, in that particular situation, in this IUC insertion has to be done in the hospital setting. Okay, so and also it will be like whether it should be offered to the IUC, they should be offered or not. The decision like it has to be discussed with the cardiologist. So you will get question from this part, so it is important to remember. So apart from this is I think is the last one. So now sometime you will get a question, patient is on anticoagulant or she is taking warfarin or anything. So can the injection or implant can be given? So your answer will be yes. Injection and implant can be offered as a choice to a patient who are on anticoagulant, because the risk of bleeding complication is quite small or very less. Okay, so risk of bleeding complication with intrauterine method is less, very small. The patient is on anticoagulant, so it can be offered. Okay, this part also is important to understand. Like if the patient is on warfarin, she had an emergency intercourse, sorry, unprotected intercourse, she has come to you with emergency contraception. So in that particular situation, you can offer copper coil or you can offer UPA with no other special warning or interventions. But if you offer them LNG IUS, so you have to check that INR is normal, and it has to be checked within 48 hours of taking it. And why it is important? Because with the if patient is on warfarin and if the LNG is given, maybe its anticoagulant effect either it may increase or decrease. Okay, so both things can happen. So you have to kind of cautious if you offer LNG to the patient who is taking warfarin. So you have to make it sure this line is from the TOG only, that INR has to be checked within 48 hours of taking LNG. So this part you have to kind of understand. So till now, any one of you have got any question can ask me. Otherwise, now I'll be giving you questions. Any question? Anyone?
Ma'am, can LNG IUS can be given in patient with anticoagulants?
Yes, it
LNG
can be.
IUS.
Yes,
So should we need to check INR in LNG IUS also?
LNG IUS, actually they have not mentioned it. They
Okay,
have
ma'am.
not
Okay.
mentioned it anywhere. Only
So it's only with oral.
oral thing, yeah. Only oral thing. This line was there in the talk, and explanation I have searched from internet because I have to explain you. But LNG IUS interaction with warfarin, I never found anywhere.
Okay, ma'am, because I thought because there is a risk of menorrhagia when we insert LNG IUS for 3 months. That's why I asked this question, ma'am.
Yeah, but they never mentioned it anywhere.
Okay, ma'am. Thank you, ma'am.
Excuse me, doctor.
Yes.
Can I see the slide before cardiac, the last slide before cardiac? Yeah, this one. Is it this one? Yeah. So can you
Yes.
explain? Like this
Yes.
one
Yes.
is.
Yes. Yeah. See, actually, if the patient has a mole and evacuation is done. So if the levels, usually monitoring is done with the HCG levels. So if they are elevated or very high, so possibility of malignancy, in this particular situation, copper T or LNG IUs become category 4. You already know that in that particular situation, we cannot, because there will be perforation. Second situation, patient HCG are falling, but normal level has not reached. So in this particular situation, if she says, no doc, I want to go for copper T or LNG IUS, so in that particular situation, it is a category 3. So you would explain her, it can be done, but it will be done in the specialist setting.
Right. Okay.
Okay.
So both
Is it clear?
IUS and IUD. Yeah. So both IUS and IUD. Both.
Yes.
Yeah.
Yes.
So we'll do that. But even though normally also a patient will do that for normal contraception, that if patient wants the IUCD, if we insert, so even though it should be by specialist healthcare professional, isn't it? Normally
For
also, it, yeah.
which condition? When the HCG becomes normal?
No. Normally, that's not HCG. Normal patient, if we insert the copper T, so it can be done everywhere. It should be
Yes,
also
yes.
that.
Yeah, it can be done in the GP surgery. It can be done in the contraception clinic.
Yeah, it can be done, but not
Yes.
that hospital setting also. They are
No.
doing after.
Why? No,
So
Dr. Salma.
yeah,
Uh,
I
uh,
understand. Yeah, I
yeah,
understand. For this
yeah.
case only, especially it should be hospital setting. Yeah. Okay.
Yes,
Thank
because you already know perforation can happen.
you. Yeah.
Perforation
Yes.
can happen because HCG is still high. So you will
Yes.
take some precaution, because if
Mhm.
perforation happen in the clinic,
Yeah.
hospital, GP surgery, and patient has to shift it to hospital, so there will be
Mm.
so much of time lapsed. Okay,
Yeah.
so this we
Yeah.
are doing in a hospital setting, specialist setting. If anything goes wrong, so
Mhm.
she will be taken care of immediately. So in this
Yeah.
particular situation, it will be done in a special setting or hospital setting. But
Yeah.
any other property, it can be done in the contraception clinic, or it can be done in the GP surgery.
Yes. Thank you.
Is that clear? This you
Yeah.
wanted to
Yeah. Thank
ask.
you. Yes. Thank you very much.
Okay, welcome. Okay, so now it is questions for you, and all this so now there are the questions, so you can give me answers. Okay, good. Everyone understood good. So answer is C, lactational amenorrhea method, because if the breast frequencies increases, so it kind of will become more effective. Another question. Yes, very good. So you people understanding very well. So it is C. So it has to be done in the hospital setting. I just explained. Very good. Best contraception for Essen-Mingold syndrome will be implant.
Yeah, ma'am.
Yes, barrier.
Ma'am, I have a doubt in that previous question, please. Why barrier? Why not COCs?
This question,
Yes, ma'am.
why not COC?
Okay, she has a missed miscarriage because it's category 1 for beta HCG, irrespective of beta HCG level in case of molar pregnancy.
Yes.
So
Yeah,
why not
COC.
B?
Yeah, B could be an option.
So
B
yes,
could be
why
an
could
option.
not be? That's why. It's more reliable than barrier contraception, no? So it should be. I thought it should be B.
Yeah, you are right. But actually, this guideline, this question is before this guideline. Okay.
Okay,
Therefore,
so what should be the answer now?
answer best it will be COC.
Okay, okay, ma'am.
Best will be COC because this book came in 2016. Guideline changed in 17.
Okay, ma'am.
So best will be COC. You are right.
Ma'am, C, ma'am.
Yes, C. So according to yeah, all guideline it is B.
Here answer should be E, na ma'am?
What is the? Just wait. So you have counseled a woman for appropriate method of contraception, which is evacuating. What is the correct advice? Yes,
E.
answer should be E. Yeah, answer should be E. Answer should be E.
Ma'am, how it is E, ma'am? When the normal levels are normal, we can use it copper T. Here it is not used given.
No, okay. She
So
had
it
a
should not be used till the levels are normal, no? It should not be used till the levels are normal. It's category 4 till the levels are normal.
Yeah, here
intrauterine.
tells not when the levels are normal, we can use it. Is it means like that, no?
Should
Intrauterine
yes,
devices
should
should
not
not.
be used till normal. Till normal. जब तक normal नहीं होते, we cannot use it. So it is right.
It is right. So it is the correct advice. It is the correct advice.
Option D, ma'am. Option D.
Yeah, actually book
POC
says
can be started, no?
book says B, but B and E both are right. Okay. Actually, B and E both are right. Barrier
Okay,
method
ma'am.
will prevent STA. This is also correct. And intrauterine device would not be used until HCG normal. This is also correct. Okay, so both are correct. But exam questions are like this type of thing will not be there in the exam. Yeah.
Hello, ma'am. Ma'am,
Hello. Yeah.
the question says that you have to counsel for an appropriate method. So in that case, B should be better than E, no, ma'am, because right now we'll anyways not give her intrauterine because HCG is not normalized. So if we have to pick one best, then B would be better, no, ma'am, because they're asking for counseling of an appropriate method.
Yes, both B and E are actually correct. Both B and E are actually correct. So barrier actually have an added advantage of STD. This is also right, but we will not insert IUCD until HCG is normal. This is also right. Okay. So B and E both are right. Actually, both are right. So, but in the exam questions are better. So this confusion will not arise in the exam.
Okay, thank you, ma'am.
Yeah, and now these are the set of questions that is from college only. Okay, so all questions from here onwards are college questions. So just read this question. I will show you answer again. I will show you options again. Okay, so this is the question. Have you read this? So this is the question and these are the options. So what should be the answer? Show the question again. So this is the question. So I will read it again. A 28-year-old woman, she got off from a bus, slipped, and she has a fracture. Her bone mineral density is low. So that means what that means that she has got osteoporosis. She has been on implant implant. Yeah. Now she has been using it for last year. This is BP and BMI. Okay. So one question came as J.
Ma'am,
So why? No, J is not an answer. Why J?
no, ma'am.
Because
Answer should be H. Answer should be H. No,
answer
answer
should,
should be G.
yes,
G.
answer should be
Because
G.
the patient is having osteoporosis, so she need OCPs. But at the same time, the patient will be at high risk of DVT. So the progesterone with the lower chances of DVT should be prescribed. That's why it should be G. Lowest estrogen
Yes,
and the progesterone with a low DVT should be profiled. So it should be G, ma'am.
just excellent. Answer is G. Explanation has been given already. So she has osteoporosis, so estrogen will come in the answer. She also at a risk of DVT. So the progesterone with least VT risk, that is levonorgestrel. So this will G is the answer. Very good explanation. So G is the answer. Now this is the question. So 40 years old woman married, she finished her tamoxifen treatment for breast cancer. Periods are regular and normal. Follow-up mammograms are normal. She wants contraception. Okay, this is a scenario and your table is still same.
Ma'am, you can go to the question again, please. Sorry, I missed that. Okay, ma'am. Thank you.
Yeah, ma'am.
Yes, very good. Yes, very good, excellent. She has a history of breast cancer. Tamoxifen has been taken. So you have to give something non-hormonal and reliable thing. So answer goes to copper. Very good, copper T is an answer. Another question. So this is the question and these are the,
LNG.
yes, very good, LNG.
K.
Okay, you people are doing well. Answer is LNG. Answer is levonorgestrel intrauterine delivery system. So this is the question. And these are the options.
It should be in C.
Yes, excellent.
What
Hirsutism
is
and acne, it has to be cyprotron acetate. Yes, very good. Now all other questions what are coming is from strategy. Okay, so these are strategy questions now. Previous questions are from RCOG. These are strategy. Now you read it, then you have to give me answer. So this type of question you will get in exam.
Should be dinate.
Dinette. Okay, no, dinette is not there.
It's a DMPA.
Yes, what?
DMPA. Depot.
18 years old.
Marina?
LNG.
Yes,
Then
answer is
next one,
LNG.
ma'am.
LNG, ma'am. It'll be LNG.
yes, it is LNG.
But ma'am,
Why?
patient is
Periods.
planning.
Yes, yes.
Pregnancy. Can we
Ma'am,
use
but the
implant?
patient is 18 years old and she is planning pregnancy at 12 to 18 months and she's having acne. So that's why I thought it should be OCP because LNG will not help with her acne and she requires pregnancy after 1 year only. So that's why I thought it should be COCs.
But she's having heavy menstrual periods, painful
It can be.
periods. That would be the concern, I suppose, more than acne.
And
Yes.
progesterone only pill, ma'am. Progesterone
Okay,
only
ma'am.
pill, ma'am.
Progesterone only pill. Actually, with progesterone only pill, the problem is like unpredictable bleeding is there. Okay.
Okay, ma'am.
And 1 year child.
Uh, she has got steady relationship, partner for 2 years. Periods are
will not improve the heavy menstrual bleeding, no, ma'am.
Ma'am, heavy
With painful
periods with painful. I think it should be the major concern.
yeah, it is a major concern, and their answer
Yes.
is allergy.
Oh, Marina.
Yeah. So their answer is Marina only. What is her BMI? She has got 94 BMI, 94 kg weight. In 94,
Oh,
yeah. So now condom is not reliable. 18 years of age, DMPA you will not use.
Not given.
And nobody saw this 94 kg. 94 kg weight, COC is already gone. Now left out options are IUS and POP. POP is not reliable, so IUS becomes the answer. Is it clear?
Yes, ma'am.
Yes, ma'am.
Okay. So please, so now take home message. All of you, including me, we missed weight of the patient. So this is question number 2. Answer has come. So what will be your answer? Everybody knows answer basically.
I will be cheating. We already know the answer.
Yeah. Okay.
Patient taking epileptic.
Yes. So this patient, what you have to understand, this patient has got epilepsy, and she is taking carbamazepine. So now you will not like oral pill will not be a good option. So and she has intercourse on the 16th day. So she is still in a copper range. So copper IUC will be the better method, because it can be kept as an ongoing method also, and there is no interaction with any hormone. So answer is IUC.
Ma'am, what is the copper range? I didn't get that.
What?
Ma'am, you are saying that she is in copper range.
Copper?
You
Okay.
just said
Why?
something. Yeah,
Like,
ma'am, could you please explain?
like what I said is that, okay, I will just tell you. So copper range, okay. Actually, till 19th day of regular cycle, we give copper coil. So she is on the
Okay.
copper range. That means she's on the 16th day of cycle. So she's in
Okay.
copper range. Okay.
GG. Okay. Got it, ma'am. Got it.
Ma'am, progesterone only pill.
Progesterone only
Allow
pills.
condom use, ma'am.
Yes. POP is the answer. Answer is POP, Sarajet.
Implant.
Ma'am, IUCD is contraindicated, ma'am.
Yes.
Plant should be the answer.
No. What
It's a
is the method?
contraindicated.
Yes. Answer will be
LNG.
yeah, Marina coil. Okay, I have not got that answer, but it is Marina coil.
Ma'am, property, ma'am.
Ma'am, it should be repeat dose of Ella-1.
But 20 days of cycle, yeah, Copati is the answer. But because 20 days of her cycle, already ovulation has been done, and she has got terminations and all these things. So Copati will be the best answer because that can be kept
Ella-1
as
may
a,
delay the ovulation.
yeah, but she's already ovulated. 20 days of cycle already ovulated.
It is second one, I think.
I think it's
Last one. Last one. Inform parents. There is no need to
Yeah,
inform parents.
yeah. E.
Yes, ma'am.
Right.
Yes, it is right. So there is
Yes.
no need to inform parent who need general anesthesia, because competency you will do. Our blood group we always check.
Yeah.
Safeguarding we always check. Risk and benefit we always explain. But we never inform their parents. So answer is inform parents.
It is A.
Up to 14 weeks. Up to 14.
Copper coil is better, no?
Statement is not correct.
B. 10 years.
It's effective for 5 years. That is the wrong answer, ma'am.
No, correction.
It's effective for 3 years, ma'am.
It's not correct.
B.
Question is
Not correct.
Next
It's
one,
not correct. A is
3 years.
not correct.
Ma'am, D, ma'am. Next one is for 5 years.
answer.
That is the wrong.
Next plan. Yeah, this is the answer.
Yes, ma'am.
Because non is effective only for 3 years.
3 years.
C is incorrect, ma'am. The risk of VTE decreases with the number of years. It's not increasing.
C is the answer.
Yes, C is the answer. If the motile sperm found in fresh semen after 3 months procedure, it is failure. This we just discussed.
7
You're right.
months.
7 months.
Ma'am, it can reduce the pain due to endometriosis, ma'am.
So read the question.
Yes, ma'am.
It
Incorrect,
is
sorry.
C only, ma'am.
V?
C.
CV?
Yeah, it is C. It is incorrect. They want to ask incorrect. So it is not associated with DVT. Okay. This is the correct answer. I think this is the last.
E.
Yeah, very
9
good.
weeks followed by 7 days withdrawal period.
Yes, because this patient has a cerebral palsy. It will be difficult to change every week. So we, extended use of this thing can be done. So they can be given for 9 weeks or 3 months followed by a 7 days gap. So answer is E. Very good. So with this, thanks. Now we have